Good evening, everyone. Martin, John, the organizers of this conference, dear colleagues and friends, ladies and gentlemen, thank you for the invitation to speak today. And let me say from the start that as a long-standing advocate for compassionate and public health-based solutions to the challenge of drugs, I'm really honored to pay tribute to Alison, Chesney, and Eddie Killoran in this lecture. And I'm touched that members of his family are actually here to attend this lecture. Alison and Eddie and others like them in many countries throughout the world, particularly in the region where I now work, Eastern Europe and Central Asia, inspire us all to work for more humane, compassionate, pragmatic, and effective responses to drugs and to the health needs of those who use them. So tonight, this will be a talk about AIDS, about the progress we have made, but also about the lack of progress on HIV among the most vulnerable populations, among the most marginalized groups, and about some lessons that I believe we should draw from this as we try to deliver on AIDS, but also more generally on public health, and I would say on global public goods in a world that is globalizing and that is urbanizing at an amazing speed. And I want to begin with two stories. The first is the story of André, a young woman using drugs whom I saw as a patient in 1986 in Paris. She obviously had no hope for access to an effective treatment. There was no treatment at that time. No access to harm reduction, since it did not exist at that time. She had lost her friends. She had been rejected by her family. She was stigmatized, particularly as a woman using drugs. In those days, it was almost inconceivable that women, too, would use drugs. And she ultimately died a very lonely death after a few months in a sort of hospice that we could arrange for her. Some of you may know a French journalist who writes on health, Éric Favreau, for the newspaper Libération. His first book, the first book he published, was about the life of, or the end of the life of André. And she really epitomized somehow the helplessness that I felt, as many of us, all too often in those days, as a physician in the early days of the AIDS epidemic, in the face of the lack of access to treatment, and I would say to treatment and prevention, since it was lack of access to the drugs, to the medicines, but also to harm reduction. The second story is that of Larissa. Larissa is from Ekaterinburg in Russia. You know, that little piece of Russia that is next to the Baltic, in between Baltic countries. And I met her a year ago for the first time in Kiev, in Ukraine, and more recently at a UN session where she was testifying in Geneva. She too had no hope and has no hope for access to harm reduction. She had started antiretroviral treatment, but very late in HIV disease, and only because of her sort of privileged networks and contacts. And she has no hope for treatment of her hepatitis C co-infection. She has been rejected by friends, neighbors, and family. She was stigmatized as a woman using drugs. And she had been repeatedly arrested and incarcerated, actually 6 times. She was arrested for the first time at the age of 26 for, quote, possession of drugs and for personal use, end of quote. deprived of all medications, and sentenced to 5 years of labor camp. And she says that this is the story of thousands of women injecting drugs in Russia. As you heard, these two stories are remarkably similar. But Larissa's story is not from 1986. It is from 2013. So while 25 years had passed between my meetings with these two women, their predicament was depressingly and tragically the same. So how this can possibly be somehow in a period when we're celebrating so much success in the fight against AIDS at the global level? What it is that we should do about it? What are the lessons from these failures? And these are a few of the themes that I wish to address tonight. So on the one hand, there's just no doubt the progress that the world has made against HIV/AIDS has just been extraordinary. Antiretroviral treatment has now been provided to close to 10 million people, when it was just a few tens of thousands 12 years ago. Antiretroviral treatment has particularly been successfully administered and provided at very large scale in Africa, where now 60% of the people in urgent need of treatment are actually accessing it, something that was almost unthinkable a decade ago. And as a result, at the global level, the number of new infections with HIV has been steadily declining, a third fewer in 2013 than in 2011. 1.6 million people died of AIDS in 2012, down from 2.3 million in 2005. And of the 25 countries that have achieved a 50% reduction in the rate of new infections in the last 10 years, more than half are actually in sub-Saharan Africa. There are several reasons to that success, and I'd like to dwell here a minute on these reasons for success. First, and this has been the theme of our discussions today at this conference. First, advocacy and community mobilization. That extraordinary advocacy has been driven by groups such as ACT UP in the north, Treatment Action Group in Africa, and now by their many counterparts, including in countries in Eastern Europe, where it isn't so easy to speak out. So extraordinary advocacy and community mobilization by people who have literally fought for their lives to make medicines affordable and available. The second factor is that we have seen a number of compassionate and, I would say, courageous political leaders taking brave decisions, advocating. As a Frenchman, please allow me to pay tribute to President Chirac, who in 1998, when no one was thinking that treatment would ever get to people in the developing world, called for basically what we now call in our jargon universal access. And then there's been extraordinary advances in science and technology, enabling new drugs and tests to reach people in the developing world at an unprecedented speed and relatively low cost, along with tremendous innovation in the delivery of care, in how we're delivering care in distant and in poor settings, such as what we call in our jargon task shifting, nurse practitioners, nurses basically giving drugs that in our countries are given to patients by university academic doctors, or community-based peer services and much simplified drug protocols. This is really the AIDS response, an extraordinary response, and that has generated extraordinary hope. The sort of hope that we now hear being translated into slogans such as the end of AIDS, or a world free of AIDS, or an AIDS-free generation in our lifetimes. And it is a global response that, at least until recently, has treated AIDS medicines as a global public good. A global public good that should be funded through a combination of national and international financial support and made available at the lowest possible price. And please remember that to achieve this, to achieve access of these drugs to the poorest, the international community, under pressure, had to generate public health exceptions to the intellectual property protection system that actually rules the price and sets the prices of medicines worldwide. But what I'd like to say tonight is that, sadly, this is not the whole story, because we may contrast this progress with, on the other hand, a grievous failure to respond effectively to HIV among people we call the key affected populations. And here I refer to people who inject drugs, such as Larissa, to sex workers, men having sex with men, people in prisons, transgender populations, and increasingly migrant labor, who are at the center of the epidemic in the region where I work now, and in many cities, I'll come back to that, and many communities around the world. Among these groups, the response to AIDS, I would say, is a story of indifference and neglect. And actually, I would see no reason why the international community wouldn't also generate a public health exception to, for example, the 1971 UN Conventions on Drugs that, Roy, we were discussing this afternoon, just as it generated a public health exception to intellectual property rules to have the medicines reach the people. It has long been assumed that key populations represent only a modest share of the epidemic globally, and that the prevalence of HIV among them is largely confined to countries with low-level epidemics that we call concentrated epidemics. But if you think of it, these key populations in fact represent a major share of the global HIV epidemic geographically, if not numerically in absolute number. That is, most of the affected people outside sub-Saharan Africa, and an increasingly recognized share of infections in urban settings in Africa. Let me just give you a few figures. In low and middle income countries, men who have sex with men and female sex workers are 19 and 13 times more likely to have HIV, respectively, than the rest of the population. A recent review of the evidence by Chris Barer and others from 15 countries found that nearly 20% of transgender women are living with HIV. Key populations, all put together, and their sex partners account for as much as 51% of new infections in Nigeria, 33% in Kenya, 28% in Mozambique, 80% in Morocco, 47% in the Dominican Republic, and 65% in Peru. Men having sex with men account for more than 33% of new infections in China, and projections indicate that MSM could make up half of more of all new infections in Asia by 2020. Could I have the slides, please? And of course, we also have failed to control the epidemic among gay men in the global north, in our countries. the rate of new infections in the US has increased for at least a decade. And this is also the case in the UK. And as you see on this slide, with the blue line on the top, increase in infections in France among MSM as compared to the stable. And for example, for the red line at the bottom, the stable and very low epidemic, that is rate of new infections among people using drugs in the country where harm reduction is available. Now, this is a slide about Thailand. When it comes to people who inject drugs, the prevalence of HIV is somewhere about 20 times higher than that in the general population. And here what we see in Thailand, and what I'd like to show you, is the contrast between the red line, which shows the decrease in HIV prevalence among female sex workers in Thailand from somewhere above 40% down to around 5% over 10 years, and contrasting as well as among their clients, and this is the dark blue line on the bottom with a slow decrease, but at the same time consistently high HIV rates among injecting drug users, which is the upper blue curve. And this clearly shows somehow what can be achieved when there is an aggressive, targeted campaign to promote condom use among sex workers, as we know, where Thailand has been so successful, and the consequences of what I would call a ridiculous, if not an abject, failure to address HIV among drug users, including the continued criminalization of use and of possession, and the failure to implement and the denial on the efficacy of implementing needle and syringe exchange programs. When it comes to Eastern Europe and Central Asia, around 35% of drug users there are infected with HIV, 35%. And the prevalence can go up to an astonishing 70% or more in some of the cities in the Russian Federation. And the lack of progress against HIV among people who inject drugs in that region translates into a growing regional epidemic. You see the rapid growth of the epidemic in Eastern Europe in blue, contrasting with the decreasing of the epidemic in Western Europe. And that now translates in more than a regional concentrated epidemic. It is actually an epidemic that is generalizing with clear signals that the number of women heterosexually infected, and not only women who inject drugs, but actually women partners, non-injecting women, partners of people who inject drugs, are now becoming increasingly infected. Latest figure I had from the head of the Federal Russian AIDS Center just 2 weeks ago was that the prevalence, he estimates that the prevalence in Russia among men aged between 30 and 35 is now 2.5%. Very high figure. In the Russian Federation, Ukraine, Estonia, somewhere between 40 and 60% of all of the cumulative cases of AIDS so far have been among people who inject drugs. And the prevalence, as I said, can vary somewhere from between 20-25%, as it is in Ukraine, up to 70% in Estonia. As you may know, access to prevention, to harm reduction for people who inject drugs in that region, interventions such as needle exchange and opioid substitute therapy remains unacceptably and scandalously low. On an average, it's only less than 2% of the people in need in the entire region that have access to opioid substitution therapy. And opioid substitution therapy remains illegal in the Russian Federation. in that region, as you can see in red, this is also a region where the coverage with antiretroviral treatment lags behind all other regions in the world but one. And this, despite, of course, a clear understanding and evidence about what needs to be done. This is a slide taken from some modeling analysis by Louise Degenhardt and colleagues that show that high but quite achievable coverage levels in needle and syringe exchange programs, opioid substitute therapy, and antiretroviral therapy can result in significant decreases in incidence of HIV. What is shown on the ordinate here is the decrease in incidence after 5 years of implementing various sets of combinations of these three interventions. And the analysis shows that the required coverage levels are much lower and actually therefore much more feasible when these key interventions are to be combined. The next point I'd like to address or to raise is that key affected populations tend to be concentrated in cities, the theme of this conference. For many MSM, men having sex with men, and transgender people, for example, cities offer new freedom for expression of sexuality and identity. And at the same time, people in cities experience social dislocation and often insufficient economic opportunities relative to demand. So this produces contexts and patterns of vulnerability to HIV, including sex work and drug use, which can then be fueled by inadequate access to prevention and treatment, as well as human rights abuses. So we can't be surprised to learn that globally as many as half of HIV-positive people live in cities. For when it comes to HIV among key populations, we're speaking primarily of urban epidemics. So my concern is that if we continue to fail in responding to these epidemics, there is a serious risk that AIDS will become more and more of a concentrated epidemic everywhere. And this is because, first, some of these epidemics, such as those that we know are growing among gay men and drug users in African cities, are tremendously difficult to reach because the populations are so marginalized. And second, the epidemics among key populations are occurring in a context of rapid economic growth and transition to middle-income countries of many countries in the world. This economic growth is accompanied by increasing economic and social disparities. That is a widening gap between the rich and the poor, or between those that can benefit from economic growth and those who do not. These are disparities that, I might add, the international community is somehow largely content to ignore. Once a country reaches middle-income status, it is left by the international community to manage its own widening disparities, despite the fact that many emerging economies do not have what I would call the socio-democratic maturity to prioritize social development and social protection for the most vulnerable. Let me illustrate this briefly, and first show a few slides that you actually have seen this morning already, shown by Kate Hankins, showing how the number of countries classified as low income, and they're shown in red on this slide, is slowly disappearing from the map. So this is a map in year 2000. In red, low-income countries. In pale blue, the lower tranche of middle-income countries. In darker blue, upper middle-income countries. And in green, high-income countries. And this is the picture in 2010. And this is, sorry, went a bit fast. And this is the picture in 2020. But if indeed there is such a shift in between low-income countries to middle-income or high-income country status, which that is quite remarkable, this doesn't mean, of course, that the benefits of this progress are equally shared. In 2010, 70% of people living in poverty were in middle-income countries, and 60% of people living with HIV were in middle-income countries. At the same time, the world is rapidly urbanizing. And here is again a few slides, of which you've seen at least one this morning from Kate. This is a map in 1960 of urbanization and how this grows from 1960 to 1980 to 2011, current, and what it will be in 2025. And I believe that taken together, these two phenomena of global economic growth and urbanization are increasing economic, social, and political inequalities, all of which ultimately impact health, access to health services, including but not limited to, of course, HIV prevention and treatment. So it is clear to me that our future efforts to deliver global public goods, including HIV interventions to key populations, are tremendously dependent upon addressing the social, economic, and political determinants of health, including the well-known drivers of social and health inequities: lack of educational and economic opportunity, lack of appropriate accessible health and community services, and lack of participation in decision-making around health by those who are most affected. And I especially emphasize political determinants of health here, in the sense of failed and misguided policies, those based on ideology rather than on evidence. And here I cite an example that is of great concern to me particularly, and that is illicit policies around illicit drugs. Clearly, we have learned since the beginning of what has been called by Richard Nixon the war on drugs 40 years ago, that drug policies based on repression, police brutality, and incarceration, as in so many of the countries of the world today, are fueling the HIV and hepatitis and TB epidemics at a significant human and social cost. The data bear this out. Studies show, for example, that having been arrested, having spent time in prison, and the fear of experienced police violence are all associated with reduced capacity for risk reduction. Research also shows a strong and consistent association between the number of people incarcerated and HIV prevalence among people who inject drugs. So we can never make progress against HIV among people who inject drugs as long as these repressive policies continue and as long as we fail to address the social and economic issues that actually lead people to harmful drug use. So I'm almost sort of comparing our failure to adequately address these issues to the situation that a number of us in the audience knew in 2000. At that time, effective HIV drugs were available in rich countries, have been available in rich countries for years, but were inaccessible in developing and emerging economies because of cost. Today, cost of medicines is not the primary obstacle. We have the medicines and we have proven interventions. Rather, it is the social and political obstacles that prevent them from being made available to those who need them most. Take the example of Romania, specifically the city of Bucharest. Here is a country with an HIV epidemic in which new infections were primarily among heterosexuals and gay men, but which had delivered effective harm reduction interventions for many years with international support, keeping, as you can see on the left part of the slide, the proportion of people who inject drugs among newly diagnosed HIV cases, somewhere between 3 and 7%. And in 2011, as you can see on this slide, the proportion of new cases who were injecting drug users suddenly increased astronomically from 7% to 42% in 2012 and 11, and then 60% in 2012, as shown here. Studies confirmed that 93% of newly infected drug users in Romania are in urban areas. I was in Bucharest 3 weeks ago, and to me this is really like, you know, an example to be taught, certainly in universities and but at school almost, because there were two events that were coincident and that clearly explain this epidemic outbreak. First, the abrupt cessation of international funding to NGOs through the Global Fund. The Global Fund funded non-governmental organizations that were providing the services, the harm reduction services. One of the clear lessons from successful delivery to key population has been the importance of implementing it by peer community and civil society groups, as we've been discussing today here in this conference. In Romania, even though the government could continue buying needles and syringes, the organizations that had been successfully distributing them effectively ceased to operate. Because in Romania, as in many countries in the post-Soviet region, there is no mechanism and no willingness for the government to fund non-governmental organizations. And they were no more eligible. Romania, entering the EU, was no more eligible for funding from the Global Fund. Now, at the very same time, 2011, this is where a number of people injecting drugs in Romania switched from heroin, which you inject once or twice a day, to what's called now the legal highs, where you can inject up to 10, 12 times a day, a huge increase compared to what people used for heroin. So in short, a huge increase in demand associated with a drastic reduction in supply of needles and syringes. So this is the practical outcome of Romania's economic growth, a worsening of this overwhelmingly urban epidemic among people who inject drugs. So my conclusion this evening is that we need to urgently rethink our AIDS strategies and focus more attention on key affected populations if we are really to speak and think one day of ending the AIDS epidemic. In an era of widening inequities that are driven by increasing globalization and urbanization, as I have been arguing, we will fail to stop the AIDS epidemic among these populations unless we pay more attention to the social, economic, and political determinants of health. This includes continuing to fight against misguided and politically driven policies on drug use, for example, that prohibit access to crucial interventions and punish users rather than they respond to the pressing health and social needs of that population. In addition, we cannot just think about the roles that national governments and the health sector play, important though they are. If there is anything we have learned from AIDS, it is the need for effective local responses, including municipal responses. And here what happened in Bucharest, actually, is that when almost the last of the NGOs was about to close, the city of Bucharest provided that NGO the funding that allows that particular organization to still run its programs. Or I'm thinking of the city of St. Petersburg that actually stepped in to fund needle and syringe exchange despite that the Russian government is not accepting these interventions. Or, of course, I think of the successful work here in Glasgow and in Edinburgh on HIV and hepatitis, and the perspectives I hear of perhaps actually almost eradicating hepatitis in a few years from the region. These responses are successful because they recognize that the public sector cannot do it alone. They must involve close collaboration with affected communities at every stage of planning, implementation, evaluation, and governance. At an international level, we need, I believe, to keep the idea of global public goods, that is dear to my heart, on the radar. Because global public goods are the driver, have been the driver, if we again take the lessons from AIDS, of effective action on health at the global scale, while at the same time recognizing what this conference is all about, that if we do not deliver on public goods locally, then we will fail to deliver them globally too. So as we work on improving the health of countries, cities, and the people who inhabit them, let us also never forget how powerfully we can use the health agenda and health to increase equity, to actually accelerate the fight for human rights, and ultimately to give hope to those who need it most. Thank you very much.